everyone. Today we are with Ceren and Rahat to talk about mental health needs, service provisions and supervision related to displaced communities' mental health. I'm here with Ceren and Rahat. Thank you very much for your time to join us today. We are so looking forward to hearing your experiences and how you interpret the mental health needs, service provisions for the Rohingya and Syrian displaced communities in your countries. Good morning and welcome.
Good morning. Thanks for having us, Gülşah and Amar, and hi, Rahat.
We first would like to start with asking you, what are the mental health needs of displaced communities in your countries, in Turkey and Bangladesh?
Shall I start? Yeah. So, more than a decade, actually, Turkey has been hosting Syrian refugees mostly, and we also have asylum seekers from Afghanistan. But in the Syrian community, we can say that the research and the reports all are showing that common mental health problems such as depression, anxiety, and also post-traumatic stress disorder symptoms. These are highly seen among refugees, both children and adult Syrian refugees. This is one case, and in Turkey, different than other countries, some other countries, Syrian refugees are residing in the urban setting. So, though at the beginning of the crisis, we had temporary camps where the Syrians live, mostly around the border, but currently, maybe in the last 5 years, we see an increase, and more than 90% of Syrian refugees are in the urban settings. And this also brings some other difficulties in terms of health access and also mostly post-migration living difficulties related topics. So maybe Rohat can also introduce what's happening in their country.
Yeah, I think the context is a little bit different in Bangladesh because, as you said, Syrian refugees are working in with the cities, but in Bangladesh they are living in the camps mostly, and they are living in close proximity with the host community, and sometimes they are collaborating together in some cases, sometimes they are quarreling as well. So because the resources are very limited. However, we are hosting the refugees for over 3 decades now. The recent outbreak was 5 years back, and before that we have been hosting Rohingya refugees since 1990s, around that time, and before that as well sometimes. So the most common problem they are facing is like PTSD is obviously a concern, and then we have similar to you, depression, anxiety, and those things. However, the practitioners working there are mostly concerned with the vague symptoms. It's not diagnosable condition because they present with vague symptoms. For example, they are having some somatic complaints. The causes are not identifiable with any disorders. Something like that, sleep disturbance, frustration, hopelessness, those things are very common as well. And there is an increasing trend in suicidality, especially in some camps. And there is also increasing trends of violence. Within family violence, domestic violence, those things are increasing, and polygamy are there as well. So women feel disturbed with the husbands moving to different camps and they are lost, something like that. So it's very difficult for them living there.
Yeah. As you said, Rahat, it is not always diagnosed cases, but we also see this hopelessness, especially in the in the recent events, like about the rights, because Syrians' condition is different. They are not accepted as refugees according to the international law, which we say refugees have rights, but in Turkey they have a special condition, which means they have temporary protection, and this of course brings the uncertainty. So uncertainty about the future, about their rights, is also affecting their mental health, and especially the political climate, which is seems to be very much depending on the next election in May, Turkey is also creating another stress, what we see, because there are two opponent powers, and one is supporting refugees, Syrians, one is not. So what will happen in May is also important for their condition. So this uncertainty, I think, when we are working with our groups is very important. And besides the violence at home, we see also children has to work. This is maybe a little bit beyond the scope of mental health, but it is very much related with that. So for children, for youth, we see that child labor is also a problem, and child marriages are also a problem in our refugee group.
Yeah, child marriage was also a problem in our context as well, in our refugee camps or forcibly displaced Myanmar national, because we don't give them refugee status as well from
Okay.
Bangladesh government. So
Yeah.
we call them forcibly displaced Myanmar national because they are displaced from Myanmar because of the atrocities and those things done. And additionally, as you say, the child labor and child marriage thing, child marriage is a concern here as well. However, the government and the committee working over there, they have made some provision that the families are not allowed to marry the child off before certain age. So we are trying to impose those criteria, but still, this is the local committee, and they have their own norms. Sometimes they try to violate those norms in a hidden manner. So those are there as well.
Yes, it's very similar, Rahat. So the law, Turkish law also has certain regulations about the age of the marriage, and most of the time we hear the community also, the public knows about this, because due to the birth. So when the child gives a birth at the hospital, the doctors has to report it, and then the public also learns about it. And other than that, as you say, they have their own norms and their own way of living, and there is this discrepancy between the host community and the refugee groups, especially in terms of the marriages, like you say. It is not allowed in Turkish law to marry more than a woman, but it is different in their culture. So we see also these kind of differences can affect the conflict between these two groups. But if we go back to the mental health, yes, they have higher rates of mental health problems. But when we think about the access to mental health services, we had done a study around 2019 in Istanbul with London School of Hygiene and Tropical Medicine, Professor Roberts and Fuhr. So we found that even though the mental health problems are high, just around 9% of those who have mental health problems and who accept that, who are actually aware of that, use mental health services. Of course, the language barrier appears as a very important barrier in our context, because their language is Arabic and we don't, it's not the official language of Turkey. So that is one barrier, but also we found that stigma related factors are affecting the lack of the access. So I wonder, in your context, what is happening there?
I think we are having a very interesting issue here. For example, in the host community in Bangladesh, the treatment gap is 92 to 94%. That's a huge treatment gap in the host community. Yeah. However, in the camp context, because lots of INGOs are working, they have lots of mental health professionals. So I believe the treatment gap is much lower in the host community, in the camp context. So that's interesting. However, the big problem is that the mind-body relationship. So in these contexts, people doesn't believe in mental health problems. So they believe in physical health problems. So whenever they are having some mental health problem, they either term it as physical health problem, or they term it as gene position or spirit position, something like that. So black magic and those things. So they go for those kind of treatment as well. So we are trying to work with these issues by involving traditional healers. So in some training, we are providing training with the traditional healers that in this case, they can refer them to mental health professionals, something like that.
I think this is a great way to overcome this barrier. So very, very good.
But still, it's there. We are trying our best. The most interesting part is that people are increasingly understanding the need for mental health support, especially the women. So when they are suffering, they come to mental health service providers. And after getting some service, they are increasing their visit nowadays. So previously it was only one visit, and now it's increasing the number of visits. So
that is
there's a
also
hope.
showing that the first visit works. So that's very important to make them to come. Probably great. And as you say, women are more open to use these services, isn't it? In our context as well.
Stigma is there, but I think I'm not sure about the host Rohingya community, but in host communities, in the younger generation, the stigma is decreasing automatically.
Yes. Yeah. I think similar here as well. And even the Turkish community, we see young people are more open to accept that these mental problems and use services, as you say. Yeah. Yes, stigma. I remember one of the findings in our study, that mental health gap study, 1/4 of the group said that we don't want to use these services because our families might be ashamed of us if we go to a psychologist or a psychiatrist. So that stigma is really seen, but we did a similar thing as you did with the traditional healer. So we tried to communicate with the community leaders in the camp, and at the border we made one study, and then we can recruit more people. Before we contact with the community leaders, nobody came to this because we thought that we have a great intervention and people really can benefit from it, especially for trauma, but nobody came. So then we changed our mind and we said that we should find ways to actually open these gates. Otherwise, you can have the best treatment, but if nobody comes, it wouldn't help.
I think that there's additional barriers. For example, mental health it doesn't happen in the limbo. So it's connected with all the other services as well. For example, if you are concerned with physical needs, then you don't worry about mental health needs, something like that. So people are more concerned about their daily living, for example, their foods and security, those kind of things. The security is decreasing every day. So there are lots of concern. Groups are fighting each other. So there are lots of concerns there as well. And whenever we talk with the younger generation, specifically in the camps, so they are all concerned about their education. So they had hopes, but now they don't see any ways to get those hopes because educations are very difficult in the camps. They have provisions for minimal level of education, not for higher studies. For example, they can't go to universities. It is shocking to talk with many of them because some of them were saying they want to be a doctor or an engineer or a teacher, but they can't go to, they don't have any access to education. So that frustrates them as well. And when they see these things, they feel that it's mental health will not help us. We need those kind of support. Additionally, I think empowerment is a big issue. That's also a big barrier for mental health. So in the camp context, lots of NGOs are working to empower the women because they are suffering. They have their resource. They cannot get access to their resources. So in camp context, the NGOs beautifully built some. They called it Shanti Khana. That means Center for Peace or something, Center for Comfort and Peace, something like that. So that's our women-friendly spaces. So women go there and they are very happy with that, but the male members of the society in the Rohingya camps, they don't like it. So they think that you are brainwashing our women, so they are becoming more dominant or something like that. So that's another barrier to reach mental health service. Yeah.
So you're changing one side of the unit, but then it can create those problems. So yeah. I think what you say about this, we always investigate these factors like post-migration living difficulties. And what I hear, like lack of education opportunities or lack of the job opportunities. So these are very important, and focusing on mental health needs without considering these PMLDs actually would be missing. And in Turkey, we see the similar thing, especially with COVID times, restrictions, lack of the access to work, and this decrease in the job opportunities, and closing of the schools. So they all created more and more problems in general, and they may then underestimate the mental health services, which makes sense actually. In the supervisions, we also hear that when there are these financial problems, when they are getting bigger and bigger, it is getting more difficult to talk about mental health with the refugee groups, which actually our facilitators or even the supervisors are also seeing this, and it's getting more sometimes difficult, and sometimes it is creating more hopelessness even in the facilitators.
Obviously.
Yeah.
And many people think it's all about Maslow's need hierarchy.
Yes.
So people need those basic needs first before they can go for mental health needs.
Yeah.
Even in the policymakers, they have those kind of thoughts. So you don't have to worry about mental health. There is too much mental health. Let's talk about the physical health and those other things.
Yeah, I think we should be there and say that both are important. So it doesn't mean that you should ignore the mental health needs. So I also getting more interested in these integrated interventions recently. So how we can integrate the mental health components, modalities, with more modalities focusing on practical needs. So yeah, we should focus on tap on both of them, I think.
And you were both talking about like the community leaders, traditional healers, and their role in providing services to displaced communities. If we consider this action actually in the scope of our project, how do you see the role of supervision in ensuring the quality of available services to the displaced communities?
Yeah, actually, what I hear from the field, those who are working in NGOs or INGOs, or who are providing services to communities where there are also barriers beyond the individuals, like maybe similarly in places who are providing services to women who are exposed to domestic violence in shelters. Sometimes I hear this helplessness a lot and hopelessness, and sometimes also difficulties can even create anger in the facilitators. But this anger is not to the people, but to the system, but it can be directed sometimes to self or to others. So I think continuous sustainable supervision program is very important, especially in these groups, because the event, this is already very difficult to work with this. So when you do it alone, it is getting more frustrating and the service quality decreases. And I think that it can also even harm the facilitators, especially when the facilitators are coming from the peer groups. So that is also creating both benefits, but also difficulties. So I'm very hopeful about our program, which is one of the first of its kind. If we can understand how we can provide continuous supervision with the forces of the host communities and international groups, how we can make it really going on sustainable, I think it can be a great help to all of us.
Yeah, I think I want to add a few things with Ceren. So supervision is a mandatory thing, isn't it? We all know this, specifically in this context. Humanitarian crisis context is very challenging. It's something that we are not trained for. So in regular course curriculum, where we are trained in dealing with regular issues, for example, host communities issues, those things. But when this humanitarian crisis occurs, this is unique for all the other people. Yeah, the men who are suffering and the people who are providing service as well, even the policymakers as well. So because of this uniqueness, supervision is a mandatory thing. You need to carefully decide what to do and how to cater your own knowledge and skills into these specific contexts, these landscape, fit with these landscape. So that's one thing. The second thing is that the crises faced by this population, they are from different culture. So that's another uniqueness. So we need to cope with those culture as well. So that's why supervision is crucial. And I believe our program that we are providing service will help in this regard, not only by providing supervision, but also by providing in enhancing local resources. Because in our program, we are getting service from international community. So international supervisor will provide supervision in a cross-cultural manner. That will be a beautiful component because they will learn cross-cultural things through supervision as well, how to cope with those things. So that's one thing. The second one is we are trying to building skills of local supervisors as well. So that's a very unique opportunity because developing supervisor takes time. So we have selected some people who will gradually get those training, and they will contribute after this training is done. They will continue to contribute, supervising their own staffs in their own communities. So these two are very important. Additionally, I think, as Ceren said, that when we, as a mental health professional, we have to empathize with the clients all the time. So we have to read their problems. So without supervision, when we read their problems, we feel burdened. So with supervision, they will feel more supported. So getting beyond the burden, and they will move into how to help them more in a more skilled manner. So that is huge important because once the professional feel better, that they can serve better with the community, isn't it? So if I'm burdened, I cannot help them get over those things. So these have a dual effect. So the professionals getting more relaxed, and the same way they can provide better service to the communities. So that will be hugely impactful in the community as well. And we believe that with this supervision, the uptake of service will increase. The professional will be more confident in communicating with the service recipient that why you are doing this and how we are doing this. That will create confidence in the beneficiary as well. And through that, it will create confidence in the organizations as well, because they will understand the importance of mental health service, and the policymaker will be more oriented to provide this kind of service.
Yeah, I agree, definitely, Rahat. So increasing the competence in the service providers is very much related with better psychological health of the facilitator, and this will of course affect the relationship. So capacity building is in the system is very important, and also trauma work is difficult, huh? So we are all clinicians as well, so we know also how it can be difficult to work with different kinds of, especially human-made traumas. So I think I read, and we always in Turkey try to remember this: trauma work shouldn't be done alone. So because in our country we have been going on many different kinds of traumatic events, large-scale events like earthquakes or mine explosions. So we have some kind of experience, and we always say that we should be within teams, so bodies and teams. So that group effect is also important. What we are doing is creating safe groups where these facilitators, the workers can describe their emotions, understand and reflect on that with the guidance of the supervisor. So providing these groups can also has a positive effect. So I'm also very, very hopeful about our project.
Yeah, I think there is another part in the group supervision as well. For example, the MHPSS professional we have selected are from different organizations. So when they're coming together in the same supervision group, they will share their feelings and their thoughts and their ideas, and that will create a more cooperative workspace between the organizations. So building trust is very important, specifically trauma. People have vicarious trauma, and trust can be a very, very difficult issue. So group supervision can create an opportunity to increase the trust between the members, and I think that will create an impact.
Yeah, we hope so. So, Yusha, Ömer, do you have any other questions or?
I guess not. You have covered all. Thank you both for your time. I think we would love to see you both in the future. So thank you.
We're very happy to be here. Thanks for this opportunity. Thank you. And thanks, Rahat, a lot for all this information.
It was really appealing, interesting, and enriching conversation with you. And we would like to see you more, talk to you about like everything more.
We will be happy, I think, Rahat.
Thank you,
Thank you.
Gulshan, Farooq, and Ceren. I think this was really nice opportunity for us to talk. And I believe if we host this kind of talk regularly, not between us, but from other colleagues from other contexts in the world, that can create a sustainable resource pool. So other people, whenever the new crisis is occurring, they can review these discussions and they can find something out of it. Yeah, thank you.
Definitely, definitely.
Absolutely.
Thank you very much.
So much.
Thanks for the idea. Yeah.
Yeah.